Good morning. Dr. Sadi, before he started his presentation, he warned everyone that his presentation might be a little bit boring. Now, if anyone agrees that his presentation was boring, wait until you hear this one. Okay. I will be speaking today about implementing Meibography in our refractive surgery workup. Excuse me, where's the... This one? Okay, and this is where the... okay. Sorry about that. Okay. So we all know that dry eye disease is a multifactorial disease. It has many symptoms. Sometimes the symptoms are a little bit awkward. You cannot relate the symptoms to dry eye, but once you start treating the dry eye, then the symptoms disappear. The symptoms can be in the form of gritty sensation, foreign body sensation, burning, whatever, or can be actually visual symptoms. The tear film is essential for clear vision as it is the first refractive surface of the eye. It is an integral part in the corneal lens. And the visual quality has been in the last few years one of the most important concerns. It is well known that dry eye can affect the outcome of refractive surgery. There are many clinical tests. We've been testing for dry eye since we were residents. We all know the clinical tests for dry eye, all of which were described for the general population. They were not directed for refractive surgery patients, and newer corneal imaging technologies have been found useful in imaging the tear meniscus, imaging the tear film, and maybe quantifying the disease of dry eye. So the classic methods to evaluate dry eye, we all know the tear production evaluation, tear stability evaluation, and the lab tests. Tear production, classically, we all do Schirmer tests. Recently, we have the tear thickness measurements by the OCTs, and we can actually measure the tear meniscus height. You can do that with an OCT, with an oculus keratograph, 4 or 5, and there's a new Placido disc machine called Antares by CSO. Again, the tear stability can be evaluated by the breakup time. We all know the breakup time. Sometimes it is a little bit, subjective. You can have two doctors doing the BUT. One has a value and the other doctor records another value. Recently, you can do a non-invasive breakup time by the keratograph 5M, by Placido disc imaging. Meibomian gland evaluation, though, has been very important in evaluating the dry eye, and it is the viewing of the Meibomian gland with the use of photography, film, or video. Meibography, classically, or in the old times, were done with a contact technique. This has been done since 1977. You put a probe, you invert the eyelid, and this is an infrared camera that captures the Meibomian gland structure. Recently, there are the non-contact techniques with the use of without the use of a trans-illumination probe. The very famous is the oculus keratograph. And the basic theory or the basic principle of use of these machines is to map the areas where the patient has Meibomian glands and map the areas where you have loss of Meibomian glands. It can detect the Meibomian gland from its structure, and then it records a percentage of the part of the lid that has Meibomian glands and the part versus the area of the lid that does not have a Meibomian gland. The idea is to calculate the ratio between the area covered with glands and the total eyelid area. A low ratio determines a high probability of suffering dry eye. There are many Meibo scores. You have the Areta Meibo score and the inverse Areta Meibo score, and they are basically the same. In the classic Areta Meibo score, you have 0 with no loss of glands, 1 gland loss less than 33%, and up to 3 where you have more than 67% gland loss. For the sake of statistics, when you're doing a paper, he inverted the score, so you have a 0 where you have no glands at all, and you have high scores 5 where you have excellent glands and no loss. These are the lab tests, and there are many more lab tests to evaluate dry eye. We all know the lactoferrin, we all know the tear osmolarity, but again, there was never a cut-off point where you can say this patient is a candidate for refractive surgery or not. Dry eye has a variety of evaluating tools with pros and cons for each method. So is meibography overrated? We hear a lot about meibography. Should we implement it in our refractive surgery practice? This is the million-dollar question. And to clearly evaluate the effect of dry eye on our everyday refractive practice, to answer the question, can we link pre- or post-operative visual discomfort to changes in tear film, we decided to conduct a study. Now, the question is, if patients are complaining after refractive surgery, for example, LASIK, and if these patients, when you put artificial tears, whatever you're using, they are relieved, is this because of the symptoms that they are feeling, the dry eye symptoms, the gritty sensation and the burning sensation? When you put artificial tears, everything smoothens and then he can see better? Or is it that you've done a bad job on the cornea and the cornea is irregular, and by putting the artificial tears, you sort of couple the cornea and smoothen the surface and so the patient sees better? Or is it just normal dry eye where the tear film thickness is integral as a part of the lens? We actually don't know the answer to this question. So the primary objective of our study was to determine the effect of dry eye on higher order aberrations on patients that did not do refractive surgery. Secondary objective was to evaluate a new diagnostic tool, basically the meibography. We used the meibography on the Cirrus machine. This was a controlled cross-sectional clinical study conducted on 111 eyes. Two groups. The first eye were documented dry eye patients that were recruited from the ophthalmology clinics and from the rheumatology clinics. And group B, we had 33 normal functioning tear film eyes. To simulate post-operative LASIK patients, we chose patients that did not have a refractive error. Patients hand control should have a refractive error within 1 diopter sphere and 1 diopter cylinder. And these should have clear corneas and other ocular media. We did the normal workup for all the patients, and we did meibography with the non-contact series and measures of higher order aberrations. Again, corneal higher order aberrations, not a total wavefront, again with the series. In dry eye group, repetition of meibography and higher order analysis was done 2 times. This is the machine that we use, the non-contact meibography by the Cirrus machine, and this is the pictures that we had, and this is the software. It's called the Phoenix software, and it actually maps the area of meibomian glands and maps the dropout areas and gives you a ratio. And this is the 2 scores. This is the classic score on the top of the slide and the modified score for statistic reasons on the lower part of the slide. Okay. Now, what we found was very interesting. We found a correlation, a definite correlation between the degree of dry eye and the higher order aberrations on the surface of the cornea. Mind you, these are normal corneas, these are virgin corneas, these corneas were not touched by refractive surgery. In patients with dry eye, we found that higher order aberrations in this study averaged in 0.4 microns, and in patients without dry eyes, it was much less. We found that coma-like aberrations were much higher in patients with dry eye. We found the lowest Strel ratio in these patients, but we did not find the correlation with spherical aberration and secondary astigmatism. The amount of RMS in the dry eye group was 1.5 times as the group with no dry eye. Dry eye disease increases the total higher order aberrations by increasing the coma aberrations and the total coma-like aberrations, nor little effect on each of astigmatism, spherical aberrations, and spherical-like aberration, and there was a definite decrease in Strel ratio. This is a slide that shows you in these patients, when you put a drop of artificial tears, what happens. Immediately after eye drops, the Strel ratio rockets upwards. And it even increases after a little bit, because as you put the eye drops, the tear film is not that stable, but stabilizes within 10 seconds, not 10 minutes. Okay. This was a mistake in the slide. Again, this is the coma before putting eye drops and after putting eye drops. So, when we wanted to correlate the meibography with the symptoms of dry eye, we found that in the patients that showed higher loss of meibomian glands with meibography, they correlated very well with the symptoms of dry eye, and they correlated well with the increase in higher order aberrations that are related to dry eye, namely the coma. So dry eye disease has a significant effect on induced corneal higher order aberration, is mainly due to increase in surface instability and irregularity. Dry eye disease increases the total higher order aberration values, especially by increasing the coma, with no or little effect on each of astigmatism, spherical aberration, and with a definite effect on the Strel ratio. There is always a debate of visual affection represented by symptoms of blurring in dry eye patients in spite of very good Snellen acuity. We try to search for an answer for this dilemma, and meibography is a promising, accurate tool to assess and identify patients at high risk to develop postoperative visual symptoms. Based on the meibography tool, recent treatment like intense pulsed laser and lipoflow, which is basically thermotherapy to the lids to increase the meibomian outflow. You have an interferometer that measures the tear film, and then you have a thermal cap that you put on the eyelid to promote the tear production. I think these can be related to meibography. I think meibography is, it is not a very important tool now, but it definitely adds a little bit to the equation, as quoting Dr. Sadi in his presentation. Thank you very much.